Rabbi Benjamin Barnett. I'm the Rabbi of Beit Am Jewish Community here in Corvallis. It's an honor to be standing here right now in the room with a number of people who spend a lot of time and energy diligently, really faithfully working to create a healthier and more sane healthcare system in this country. And truly it is an honor to be here. My experience with healthcare often, in terms of what I see, is people in my community who I'm sure many of you have stories either personally or what you see as well, people who are just victims of what should just be saner and healthier and more generous and simply looking out for one another. And so our goals for this evening are twofold. One is to engage us all really in a discussion of learning more about this Affordable Health Care for All Oregon Act, the House Bill 2922. Did I just get that number right? I hope I did. Great. Okay. Didn't have it right there. And so helping us to understand this proposed legislation that's been introduced in the House, and there are some individuals here who know a lot more about that than I do who are gonna share, and we'll have an opportunity to learn together. And then also just inviting us each as individuals, whether we're part of a particular faith community or not, just simply members of the community who want to become more involved in joining that team of working toward more comprehensive, quality and publicly funded health care for all Oregon. So thank you very much for being here. The first speaker of the evening is actually going to be joining us we're going to be watching and listening to her through technology, which is Reverend Linda Walling.
Good evening. What a privilege to join with you as you gather to consider what it will mean to take healthcare reform to the next level in Oregon. Long before healthcare reform blew onto the radar of presidential politics in 2008, a multitude of faith-inspired advocates from all across the country had come together to identify shared values which pointed to a healthcare future that included everyone and worked well for all of us. I'm pleased to say that faith leaders in Oregon were a part of that process. Our work is not done. We must continue to promote values that are important to our faith communities. We must move toward a healthcare future that is inclusive, offering everyone, regardless of circumstance, access to a solid system of healthcare. We must create a healthcare future that is accessible, eliminating all barriers to that system, thereby enabling all of us to participate in and contribute to the life we share together. We must shape a healthcare future that is affordable, ensuring that we create a modern system that uses our abundant healthcare resources effectively, efficiently, and equitably. And we must design a healthcare future that is accountable, calling for shared responsibility across all sectors of our society, working in partnership on behalf of the common good. In closing, I just want to say that I am so very grateful for your faithful witness around something which is nothing less than a moral imperative. Your passion surely has helped keep alive the vision of healthcare for all in Oregon. May the one to whom you turn for spiritual renewal bless you as you continue to work for a compassionate society in which our health system affords health, wholeness, and human dignity for all.
Amen to that. Please welcome Dr. Mike Contending.
Representative Dembrow very much wanted to be here tonight. In his absence, I think we can give you a good description of House Bill 2922, the Affordable Health Care for All Oregon Act, and why we should talk about it, refine it, support it, and approve it. You may already know that about half of our population is currently excluded from good health care because of no insurance or poor insurance, and that the incentives in our healthcare system need radical overhaul. Recent federal and state laws may help some, but not nearly enough. We as part of faith communities know that silence and inaction are not options we can live with in good conscience, and that we must strive for better answers. I think that's why we're here tonight. First, I'd like to define terms. The bill that was signed by President Obama in March 2010 was called, the Patient Protection and Affordable Care Act. This has been shortened to the Affordable Care Act, or the ACA, and that's what I'll call it. Here are two characteristics of our current system that compel us out of our homes on a night like tonight. Our system costs too much, and it's dysfunctional. A 30-page article in the March issue of Time magazine tells about the uniquely high healthcare costs in the United States. One Tylenol tablet costs 1.5 cents to manufacture. Hospitals can inflate that, mark it up to 10,000% of its original cost. I'm going to leave this irony-laden cartoon up for just a little bit. It illustrates how we pay for our ICUs and our emergency rooms and our housekeeping staff. We depend on having enough people who are worried or ill enough to trigger highly reimbursed procedures like this CT scan, or coronary stents, or joint replacements. Our fee-for-service system reinforces the incentive to do more and more costly procedures, whether or not they result in better health. Other countries spend half to one-fifth of what we do on administration. Our 31% includes not just the 10 to 20% that insurance companies incur as they debate who to cover and what to cover, but it also includes the 10% or so of administrative costs that each of their providers must pay to keep up with this very complex insurance system, with tens to hundreds of insurance companies and thousands of insurance plans changing from month to month. On the average, we change insurances every 4 years because of change in job, marriage status, health status, or age. The blue line is income for a family of 4. The red line is family health insurance premiums. The two lines converge in 2025. Soon, most of us will be no longer able to afford private health insurance, and we will have to be ready with another plan. I think that's why we're here tonight, too. As a result of unaffordable insurance, 2 Linn-Benton County residents die each month. U.S. is the lowest of 16 nations when it comes to preventing death from treatable illness. We can do better than this. As a result of unaffordable insurance, 40 Linn-Benton residents are bankrupted each month. I think we can do better than that. What has the ACA done to solve some of these problems that we've talked about? The Affordable Care Act does provide a number of benefits for us, but we know that even after the ACA is fully implemented, by 2023 there will still be 31 million people uninsured, and in fact most of us will be underinsured because of what's called bronze, silver, and gold plans that cover only 60 to 80% of healthcare costs. Now there will be caps on out-of-pocket expense, but when we reach those caps, who will pay that amount that is above that cap? It's going to be increased insurance premiums. There's nothing in the ACA that keeps insurance premiums from spiraling at the rate they're going. The coordinated care organizations that Oregon is preparing, also called CCOs, are designed to unify all the fragmented pieces of the puzzle of our healthcare and will help us deliver a much better system in the future, especially focusing on preventive care and primary care. They did better in Taiwan. In 1995, Taiwan had a system much like our own. 55% of their people were uninsured. Because of unexpected changes in their politics, which could happen here, in 1995, they passed a single-payer bill. Within a year, 95% of the Taiwanese had health insurance. They've been able to keep that program going with very low increase in costs and with very high satisfaction rate. Their costs are less than half of ours per capita. I should define what single payer is. It's a term used to describe a type of financing system for healthcare such that one entity, on behalf of and directed by the public through government or a public-private agency, collects all healthcare fees and pays out all healthcare costs. Under such a financing system, healthcare can be delivered through private or public sources just as they are now. But with the public setting standards and with the power to negotiate price. This is what we don't have at the present. How do we pay for healthcare for everyone? 22 other countries have figured it out, and we're not genetically different. And they provide that care at less than half the cost of what we do. Yes, all countries are struggling with their finances. It's just that we're struggling twice as much with half the result. We can and we must do better than this. The single-payer movement in Oregon goes back to the 1990s when there were unsuccessful attempts to get a bill through the legislature. After that failed, some dedicated activists, many in this room, began circulating petitions for a ballot initiative which went before the voters in 2003 as Measure 23. Initial campaign polls were promising, but then the Oregon AFL-CIO and several big unions came out against the measure, and in the last 2 weeks of the campaign, the airwaves were flooded with ads paid for by the insurance industry. The initiative lost 75 to 25%. In 2008, Michael Dembrow was elected to the House of Representatives in Northeast Portland. He is a professor of English at Portland Community College. His family's experience with healthcare system in France and then the US has given him a long-term and passionate interest in universal health care. In the 2011 Oregon legislative session, Representative Dembrow introduced House Bill 3510, a single-payer bill. He had 10 other legislators listed as supporters and worked with single-payer groups around the state, including Portland Jobs with Justice and here with Mid-Valley Healthcare Advocates and Physicians for a National Health Program. The bill received courtesy hearing but did not reach the floor of the House. Representative Dembrow reintroduced the bill as the Affordable Health Care for All Oregon Plan, House Bill 2922, at this year's session. I will refer to it as the Care for All Oregon Plan. By now, he had doubled his number of supporters to 22, and you see some of them here. Most of them are from the Portland metropolitan area, 3 from Lane County, 1 from Lincoln City, and 1 from Medford. This time around, the bill brought 800 of us to the steps of the Capitol in February to show our support for single-payer health care. Again, the bill had a courtesy hearing before the House Health Care Committee and died in committee, and despite compelling testimony from Oregonians from all walks of life. But the atmosphere has changed now. We've had time to assess the Affordable Care Act, the ACA, and what it can do and what it cannot do. And Oregon has made progress towards changes in delivery of health care that will make a very big difference in the future, focusing more on primary care and preventative care. There is much good that is in the Affordable Care Act and the CCOs. There's much talk in the literature now, however, that these bills, this legislation will not be nearly enough, partly because there is no control on continuing spiraling upward prices of healthcare insurance and healthcare procedures. But as an indicator of the change that is happening, last Sunday, the AFL-CIO of Oregon voted to join Healthcare for All Oregon in support of universal single-payer healthcare. What does House Bill 2922 do? It provides comprehensive healthcare coverage to all individuals residing or working in Oregon. Patients do not have to prove citizenship or birth certificates. There will be criteria to determine residency. The purpose of the bill is to improve the public's health and control costs of health care for the benefit of families and businesses and society. Private insurers would have no role in this plan except to provide supplemental policies for people who want services beyond what is offered under the Care for Oregon Act. It is possible that private insurers could serve as third-party administrators, just as they do for Medicare. But in that case, the companies do not accept risk and they do not accept profit from investments. They simply perform the action of processing claims. And that's what other countries have insurance companies do. Not to accept risk or profit, just process the claims with enough margin to keep you in business. You can look in the bill and find this extensive list of benefits that are proposed in the bill. Eventually there will be public employees will be part of this plan, but if they have negotiated a healthcare benefit that is more generous than the plan itself, there is very detailed wording in this bill to accommodate those people. So one of the factors, one of the important parts of this bill is to offer people choice. Enrollees in the plan may choose any healthcare provider licensed or certified in the state or in another state for services within the scope of that provider's license or certification. A healthcare provider must accept payment from the plan as payment in full and may not bill the patient for an amount exceeding the payment made by the plan. There will be no co-payments, deductibles, or other forms of cost sharing. There will be a 9-member board. The governor shall appoint members to the board subject to confirmation by the Senate. And there must be a licensed or certified healthcare provider, a public health official, a representative of organized labor, and a representative of business who is not employed by a healthcare company. And the governor would be free to choose, would choose 5 others at his pleasure. There would be retraining for workers, a program to operate during the first 4 years of the plan to reimburse for the cost of retraining and for unemployment. A worker would be eligible for no more than 24 months for this retraining. So there would be district advisory committees allowing input as to what should be covered and how it should be paid for. There will be public hearings, accountability, options to assist the board to make this system work. A certificate of need would be part of this bill. And at any healthcare facility must obtain a certificate of need before a major improvement of any kind. So it sounds very logical in most other countries that you would have some kind of approval system before investing a large amount in very expensive technology or building. And so that we don't have heart centers building right across the street from each other. If public employees already have a plan that's very generous, that this plan would accommodate that. Also, same for retirees from public employment. Financing, it's not specified in this bill. There are many options that would be placed before the board. It could be a dedicated progressive tax of various types, payroll taxes, income tax, taxes on stocks and bonds, other taxes on unearned income, progressive surtax on higher incomes. We don't have that part for you today, but we do have a bill that passed in June, HB 3260. It's a study bill that authorizes the Oregon Health Authority to study the financial feasibility of a single payer bill like we just are showing you versus the status quo, including the Affordable Care Act and the coordinated care organizations, versus 2 other plans. We do need that information in order to be persuasive with legislators. Vermont went through this process and hired William Hcao of Harvard. He and his group did present an option to Vermont, and they did approve it, and they are in the process of developing a single payer system, but they are using the Affordable Care Act and healthcare exchanges in the meantime. But they are on track to have a single payer system by 2019. The money would be kept in a separate and distinct fund, not mixed with a general fund. No longer needed would be the Oregon Insurance and Pool, the high-risk pool, the Family Insurance Assistance Program that's meant for families that make more than would qualify for Medicaid, but still cannot afford insurance, and the Healthy Kids Connect, and the Oregon Health Insurance Exchange. It would not be needed. So the problems we have in Oregon are the same we have across the nation, and they are not significantly relieved by the ACA, the Affordable Care Act. There are many good things about that bill, but control of costs is not one of them. And the dysfunction that we've been suffering through for so many years will tend to continue. We have seen what the Affordable Care Act can do and what I think it cannot do. We've seen what the coordinated care organizations are intending to do, and I would reinforce that what we see in changes from the coordinated care organizations will be very important for our future in healthcare, focusing on primary and preventive care. And we would want to incorporate these changes in delivery into a single-payer system. So universal single-payer healthcare, we feel that it's a necessary component of any successful system. You'll be able to see by the end of the evening that there are many good features to this bill, but it's not complete yet. It will never be perfect. But through thought, conversation, and studying other successful systems, we can create a single-payer system for Oregon that can provide good quality care for all Oregonians at a reasonable cost.
So I've been asked to talk just for 5 minutes about the first vision, which is that affordable healthcare should be inclusive. It should be available for all of us, and the imperative for that from a Christian and Jewish point of view, of course, comes from our tradition. Christian tradition draws from the Jewish tradition in the first place, and that is we all created in God's image. And because of that, we are all accorded respect and dignity simply by being human. And because of that, we are accorded equal rights with each other. But even if we don't subscribe to a religious or faith point of view, I would say that we are responsible one to another and with each other as members of a common community, whether it be here in Corvallis or the state of Oregon or our nation or indeed the world. That like it or not, we all live in the same space, and we have to find ways to cooperate and coordinate our efforts if we're going to live together in a common society. I have to make a confession, if I may. I do sit on the board of directors for the Good Samaritan Regional Medical Center, and because of that, it's a great privilege to be able to do that, and I hope that I bring a faith perspective into that community. Good Samaritan Hospital is, as you know, not-for-profit, and so they're not in it to make any money. They're in it to serve the community, to serve all of us. And what I've been able to see is that, like it or not, whether we have whatever healthcare reform we have or none, right now we are responsible for each other because we're paying for the uninsured. Those of us who have insurance, whether it's through our taxes, Medicare, Medicaid, or through private insurance, or if we pay out of our own pocket, we are paying for the uninsured and those who can't pay. And right now we're doing it in the least cost-effective way possible, and that is somebody goes into the ER. By law, Good Samaritan has to give the appropriate care to that individual, whether they can pay or not. Contrary to what you might see in the cartoons or hear in coffee shops, hospitals do not check or at least hospitals, not-for-profits like Good Samaritan, do not check your insurance status before they begin a procedure or decide what necessary procedures are necessary in your particular case. To finish, I'll give you one concrete example. Last year, there were at least 4 patients who came into Good Samaritan Regional Medical Center with cardiac problems. But it was discovered fairly early on that the cardiac problems, while serious, weren't actually the initial or indeed presenting problem. The problem was chronic dental decay. And for those of you who are in the medical field will know that dental decay often leads to other systematic problems. And so the hospital had to bring in a special dental orthopedic surgeon to treat these patients' dental problems, and they were in hospital for nearly 2 weeks before the cardiac issues could even be addressed. And this is not an isolated incident. Ask any of the ER physicians or nurses or providers in the hospital, and they will tell you that dental problems are one of the primary reasons for people going into the emergency room. And that's not really a way to carry on, is it? So what we need to do is to find out a way to keep people out of the ER. One, because it will be less painful, and two, because it will be more affordable for all of us, and three, because they are like you and me, human beings, and deserving of proper health care. So, inclusive. It needs to be for everyone. I think we kind of know that. I think part of the problem, as Benjamin said, having experienced the National Health Service in the UK, and lots of people in England moan about it, in Britain moan about it, but it is really a national treasure. And of course, the United States, I believe, is the only developed country in the world that does not have single payer health care for everybody. But it is kind of a wonderful thing, even for foreign nationals. If you go to the UK and you have some kind of problem, you go to the local GP, you'll be taken care of and there will be no bill.
So other factors that would show how this would be affordable for Oregonians. Section 1, number 8 in the bill says that a healthcare provider must accept payment from the plan as payment in full and may not bill the patient for an amount exceeding that payment. And as you saw, there are no co-payments or co-insurances or deductibles. That all seems impossible, right? But most of the world has done this. Let's see. Under vision, all persons should have access to healthcare services that provide necessary care and contribute to wellness. House Bill 2922 gives us freedom to choose our healthcare providers and therefore get the care we need to remain healthy, self-sustaining, happy, and productive. You can see under Section 1, number 5, that enrollees may choose any healthcare provider. We also want to reduce barriers and disparities. So under Section 1, number 7, you can see the healthcare provider may not discriminate. Section 10, number 7, the board must make decisions that will favor culturally sensitive healthcare to all Oregon populations. So as you go through this bill, the 2922, and then the study bill itself, you can see what we are capable of doing to bring single-payer healthcare to our state. I think we'll just let
the two bills, tell me how they're connected again.
The bills are not directly connected. Both were introduced by Representative Dembrow and supported, well, 2922 was supported by single payers officially. This bill was not officially supported by the single payer groups around the state. But we feel that a good study like this is going to be necessary to be persuasive to legislators that single-payer healthcare system would work.
When I was asked to reflect on this bill and how it aligns with our values, or let's just say for a moment, my values and how I understand what Jewish tradition specifically is asking of me and asking of my community, and I would say religious tradition in general, it almost feels like I don't even know where to start because it feels so foundational. Just this basic notion of, wow, shouldn't we be providing just basic needs to one another? I mean, that just seems like the bedrock of any religious tradition, of any spiritual tradition. If we really feel like that our lives have purpose and meaning and matter on some level, that should just be the foundation of what it means to live in a community. And when I think about it, in Jewish tradition specifically, there's such an emphasis on on healing, on the value of life. Again, I think what I'm talking about is so universal here. But I'm just reflecting on in the rabbinic tradition, and there's again and again a repetition of the sanctity of life and the centrality of healing. And the rabbis really make a point of underscoring that we're not just talking about individual when we encounter someone who's in need of healing to do what we can to heal him or her, but the Talmud, so the main body of rabbinic literature, rabbinic teaching, really expands on the verse from Leviticus, you must not stand idly by the blood of your fellow, right, which is held up in many different contexts. You must not stand idly by the blood of your fellow, to say that that's our obligation to include, to provide health care, to provide medical care for anyone who's in need, and that this is a collective responsibility, right? Not just an individual responsibility. So whatever resources need to be spent to provide for that. And again, another verse, that you shall love your fellow as yourself. And I think about that in terms of the Torah, that really we talk a lot less about rights and much more about responsibilities. And I think, and I love these shirts, healthcare is a human right, and it's so true. And I think I see it more so through the lens of that providing care for one another is a human responsibility. I think very much in the spirit of what Simon was saying, this just feels like a basic responsibility, and we have this classic notion in the Torah that we need to leave the corners of our fields for the widow and the poor and the orphan, that the idea that what we have is not ours, and it's just a foundational notion of what the Torah teaches. And again, I think of just what religious teaching is in general, is that what we have is not ours. This earth is not ours. Our lives are not ours. In other words, that they are ours to tend and to steward, but not ours to hoard and not ours to hold. And so in a certain sense, that it just seems basic that we see ourselves as having collective responsibility, and that once we do, then this notion of accessible is just so necessary. To think that there are people in our society who actually don't have access to medical care just is really, it's beyond disturbing. And so I would underscore that and just say that to the extent to which we can see our needs as shared and as collective, then the vision and the values that are expressed in this bill is just a natural expression of what a commitment to religious life or to spiritual life or just to conscious life would look like.
And I would just like to add that I think having talked to a lot of people, not only in this community, but in other communities, people who are afraid of single payer or government involvement in this, it really comes from a place of fear. If I have to share, will there be enough? Will I be able to see the doctors that I want to see? Will I have the care that I think I'm entitled to or medically necessary for me? And so there is a great deal of fear. And I think one of the things coming from a faith tradition is that our decisions or our way of life cannot be dictated by fear. As a person of faith, I try to live it from a perspective of hope. Hope in the goodness of human nature and the goodness of creation, and hope that things can get better. And so, in other words, I think if we're making decisions simply based on fear or a fear of scarcity, we will not make the right decisions. One example is how much money we spend on pharmaceuticals. And we are the only country whose government does not sit down with the pharmaceutical companies and negotiate how much Big Pharma can charge us for basic medication. That's why Canadian drugs are so much less expensive. Sorry, my time's run out.
One of the things that we do have in this country that I think is admirable, and I think is something that I feel like I've inherited and a lot of people inherit, is a certain sense of independence, and that's a beautiful thing in certain contexts. And I think there's a way in which, exactly as Simon just said, I think there's a way in which that can really limit and cut us off and really be moved toward more of a sense of what's in it for me, and not necessarily have it be an assumption that we are on this earth to share with one another. I mean, just thinking about in the It was this last presidential campaign or the one before where what was the phrase? It was resource sharing, or what was, I'm not remembering what the phrase was, that became like a dirty word that you couldn't use, and I just, and it's just a really, anyway, I'll pass.
I think one of the big things, apart from fear, or maybe fear is got something to do with it, is money. Healthcare is a generator of about, 1/7 of our gross national product 18%. In this nation. There's a phrase in Christianity which talks about principalities and powers. It comes from one of St. Paul's letters to the Romans. And he says, we're not contending merely against flesh and blood, we're contending against the principalities and powers. And I think part of what he was meaning by that was, we're up against systems. I mean, look at the government, for instance. How can it be that the majority of people who are elected to Congress are, good people, and they got elected because they wanted to make a difference and work for the common good, and yet here we are with the government shut down. That's because of the system. There is a culture that is created over time, and I think that's true with our healthcare system. There is a lot of money involved. And it goes from the top to the bottom, or the bottom to the top. I mean, friends of mine, for instance, who are physicians in the UK, look with some envy and yet also some dismay at, say, how much physicians are paid in this country. I don't want to give figures, but I've, having sat on the board of directors, not that I'm directly involved in that, but some things, kind of come across our desk occasionally. I'm really surprised at how much it costs for us to pay physicians to come into our community, and it's a market kind of system. If you're not willing to pay $300,000 or $350,000 for a urologist or oncologist, then good luck to you. Then we just don't have one in our community. Of course, you might say, well, it costs a lot to go to medical college, and you have a lot of bills to pay off. I understand that. So maybe so you see, it's part of a bigger system. But gosh, if Taiwan can do it,
we can do it.
The last comment about Taiwan is a segue to the first question chosen here. Taiwan's healthcare system. How have the doctors' pay and annual income been affected, if anybody on the panel knows this, and do the medical providers and hospitals support this plan now?
There's an expert in the audience who can answer that if he's willing to come to the front. Dr. Chi.
Corvallis is rich in resources.
There's no perfect system in the world. They do have some problem. The problem in Taiwan is the reimbursement system seems to be in favor of bigger hospital clinics. But still, the private practitioners, they are making a good income. It's probably hard to believe from my consulting work. I have a preview to see the payment. How much the government has been paying the physicians. Even under the national health insurance, in the east region of Taiwan, the average monthly government payment to private practice physician was about, this was 2005, 2006, was about $30,000 US. Considering Taiwan's per capita income at that time was only 15,000 per person per year. Those physicians are getting 30,000 per person per month. So you can see why they are supportive of the system.
Dr. Chi, stay there. There's a second part of this question that I think you may be better suited. You don't take a seat, just get a microphone. A hospital administrator told an audience last year, apparently here, that there was only one country in the world that has a single-payer healthcare system, Canada. Is that not true?
No, Canada is not the only country has a single-payer system. By single-payer, we mean technically there's one entity that does all the finance and payment. And besides Canada, Taiwan is also a single-payer. South Korea is also a single-payer system. And there are numerous Western and Eastern European countries, they are single-payer system. And over the last few years, last decade, Eastern European countries went through transition. They used to be what we might call single payer, but it's actually a different system. It's a national health service like the British system. But at the end of the Cold War, they sort of dismantled the former system. They went through transition over a decade. But now many countries like Czech Republic, Hungary, they're moving towards single payer system.
If the plan to have no co-payments or deductibles as planned in HB 2922, is that a viable idea? Does it not encourage overuse by hypochondriacs?
Well, I think it just gets back to other genetically very similar people have figured out how to do this. France, for example, if you have a chronic condition like cancer or congestive heart failure, hypertension, you pay no copays. Why? Why does France find that the right thing to do? Well, it's pretty easy, right? If you keep people's chronic diseases under control, they don't end up in the emergency room and in the ICU and costing the whole system lots of money. That's separate from the idea of a government providing care that reduces suffering. I mean, that's probably the most important part about that. So there's both economic answers to that question and faith-based and just downright logical reasons that we should reduce barriers for people to get health care.
Okay. Will the Affordable Care Act pave the way to single payer, or will it divert the country away from a truly affordable and fair health system?
It's hard to know. Many physicians were, single payer supporters, were almost disappointed that the Affordable Care Act passed because it looked like it would be a Band-Aid or a shot of morphine that would just prolong the agony. And in some respects, it might be better to go through this awful crisis that we will need to realize that single payer, that private health insurance cannot provide a public good. I don't think insurance companies are bad. They simply are being asked to provide something they cannot do, a public good. So I think one of the many good things about the Affordable Care Act is that it's brought up the public awareness that yes, we should all have health care. And yes, we should not be denied health care because we were sick once. Or we shouldn't have it taken away from us because we do get sick. It has raised our consciousness to that. The problem that it has left us with is an unaffordable long-term situation, even after short-term benefits to people of low income.
How will this act affect workman's comp insurance and auto insurance?
Potentially, it could reduce workman's compensation because a large part of what we pay for workman's compensation is medical bills, I am told.
Maybe I'll take a shot at this one too. How willing have you heard that insurance companies would be to depart from the traditional business model and participate in a non-profit model? From what I know from my reading over the past several years, the answer to that is probably not very willing. As the Reverend mentioned earlier, that greed, profit, interest is a huge part of the political pressure to maintain the status quo. The Affordable Care Act, however, did a couple of really good things, a number of really good things, one of which, until this last December, when the Republicans closed that opportunity, they allowed the formation of nonprofit health insurance companies in each state. Unfortunately, only 26 nonprofits were formed, had applied for, and had been accepted by the administrators of the Affordable Care Act before the Republicans. I don't mean to be partisan, but it's the truth. The Republican Congress closed that opportunity last December. And so Oregon was lucky in that they had 2 nonprofit insurance companies apply and be accepted. So Oregon has much more nonprofit than its fair share, according to the distribution of nonprofits throughout the country. Which of the following taxes do you consider most equitable to finance this act in lieu of premiums and co-pays? A surtax on higher incomes, transaction tax on stocks and bonds, income tax based on ability to pay, and employer payroll tax? Or do you want to just say all of the above?
Probably a mix of all. But sales tax as well.
In Oregon?
Absolutely, absolutely. I think nobody likes to pay tax, obviously, but I think it's. I'd say two things. One is obviously I think we're all aware of the growing inequality between the very wealthiest 1 or 2 or 10% and everybody else, and I think there's a genuine argument for that group not paying their fair share. Having said that, I think we also have to recognise that if it's really going to work and if this is going to be something that we all feel a part of, we all have to have some skin in the game, one way, shape, or another.
Do you have to?
The bill allows for those people who will be displaced by this bill, that is clerical workers. If we match what other countries do, we will need 1/5 of the clerical workers that we have now. What will they do? Well, many of them working for insurance companies already know a fair amount of medical thought and language, and would be good candidates to learn how to give care instead of deny care.
I'm going to begin with a quote from Joseph Stiglitz. Joseph Stiglitz is a Nobel Prize winning economist. He is the author of Inequality, The Price of Inequality. This quote is taken from this book, Healthcare Wars by John Gaiman. The subtitle is How Market Ideology and Corporate Power Are Killing Americans. I heartily recommend it, particularly in terms of answering your questions about the role of the medical industrial complex in healthcare issues. We have created a society in which materialism dominates moral commitment, in which the rapid growth that we have achieved is not sustainable environmentally or socially, in which we do not act together as a community to address our common needs, partly because rugged individualism and market fundamentalism have eroded any sense of community and have led to rampant exploitation of unwary and unprotected individuals and to an increasing social divide. There has been an erosion of trust, and just not in our financial institutions. And he ends this paragraph with a hopeful statement. It is not too late to close these fissures. And I ask you, after the news of today, looking at what's happening with our government, whether that is a reasonable question. How close are we to not being able to close these fissures? And I want to share with you some personal reflections. And it relates to what the title of this conference today is. Healthcare for All Oregon, a moral imperative? I'm not sure whether that's a question or a statement, something for us to deliberate about. But I want you to think about it. I want you to think about the concept of a moral imperative. And I want you to look at what happened today in Washington. The front page of the New York Times today said, the conservatives are standing fast because they are right. That sounds to me like a justification for a moral imperative. And I ask you, is that sort of justification going to allow us to arrive at morality, or will it lead us into paralysis? Paralysis of unending conflict. I think morality is about the possibility of change. Morality is a dynamic concept. Morality is not about a set of prerogatives, but a set of possibilities. I want you to think, if you have recently seen, since this is the 50th anniversary of the March on Washington, if you've seen Dr. Martin Luther King's speech, and remember the trajectory of the speech. In the first, perhaps 3/4 of the speech, he's reading from the text, as I will do today. But then faintly in the background, there's a woman who says, "Tell him about the dream, Martin." And he looks up and he begins the "I Have a Dream" speech, which is all about possibilities. Let me begin by defining some concepts that set the frame for this discussion of strategy. Healthcare for all Oregon sounds straightforward, but it contains a set of various concepts and structures. First of all, it is an idea that carries our standard and expresses our moral position. Thank you. This idea establishes our goal and creates an objective which can be measured as a criterion of success and efficiency. Second, Healthcare for All Oregon is an organization/coalition of member organizations and regional chapters. When referring to it as an organization, I will use the acronym HCAO. Lastly, Healthcare for All Oregon is the title of a legislative proposal that Representative Dembrow has introduced. The goals of HCAO are to win passage of the Healthcare for All Oregon plan and to support a similar effort on a national level. We're focused on winning the first goal and have included in our strategic plan, which is a dynamic and ongoing process, the following operational objectives. 1, develop membership and infrastructure of a broad, effective statewide coalition of working activist volunteers supported by core leadership and staff. 2, secure necessary ongoing financial resources. 3, organize and mobilize a powerful statewide base of activists. 4, develop a legislative strategy that can win the struggle for meaningful healthcare reform. And 5, develop a communication frame that conveys our moral standard and shifts the terms of the debate. We've made significant progress on many of these and continue to work on strengthening and implementing them. Our organization is growing and our numbers are increasing monthly. We hired a capable and professional organizer who has promoted the addition of new member organizations, now totaling 88, and developed 19 local grassroots organizations around the state. A consultation from a professional fundraiser provided recommendations on our finances, and a comprehensive legislative strategy is in place. We had a measure of success in the last legislative session with increased sponsorship of Representative Dembrow's bill and the passage of the bill on the study options for financing healthcare delivery in the state. We intend to capitalize on these achievements to develop more activist leadership. Crucial to our strategic planning must be creating organizational capacity so that the implementation of the plan keeps pace with our strategic goal timeline.
I offer the following recommendations regarding the planning process. The development of a strategic plan must start with an analysis of the circumstances one wants to impact before identifying the goals and the operation of the plan. Without an understanding of the history, structure, and function of the domain which you intend to change, your efforts will be aimless and ineffective. You must assess the context of the domain, how it functions as a system with and related to other systems, so the reforms are established on a base broad enough to be stable and sustainable. I'm concerned that if our well-meaning concern for the healthcare crisis focuses narrowly on the healthcare system, even if we succeed in creating the kind of system we desire, we will still be forced to struggle for fairness in all the realms in which health is embedded. employment, education, housing, and environment. A review of developments in the economy revealed that the healthcare is but one realm, albeit perhaps the major one, in which critical changes have occurred in the past 30 years. The underlying forces which produce the healthcare crisis impact our entire lives, so our efforts to create change in health must comprehend the health of our community, political, and economic systems. Our mobilization to organize change must relate to the issue of jobs, schools, environment, housing, social justice, and governmental policymaking. Is it a coincidence that we gather today on the day that the government operations were threatened with a shutdown unless Obamacare is defunded? Coincidentally, the same day as the start of enrollment in the insurance exchanges? No. It is all part of the same process, the one which will bring the XL pipeline and Trans-Pacific Partnership unless we join together to stop the corporate control of everything for the benefit of the few. These conditions, declining wages and benefits, outsourcing of well-paid jobs, challenges to collective bargaining, contraction of work hours to avoid eligibility for benefits, deregulation, outrageous income and wealth inequality, privatization, financialization, globalization, ownership of politicians and media have resulted in a pervasive cynicism that nothing can be done about them. On the issue of healthcare reform, we saw the intense battle over the Affordable Care Act, which was throttled with compromises to satisfy insurance and drug companies and forced to abandon the public option. Despite its passage and a convincing presidential mandate, we have witnessed 41 fruitless attempts by Congress to overturn it. We see many who believe in healthcare reform and the advantages of a single-payer solution skeptical about its political feasibility. Doctors and administrators beholden to their corporate employers recognize the soundness of publicly funded universal health care, also known as single payer, but deny it because of their dependence on the status quo. The elimination of the meme that true reform is unrealistic or politically infeasible must be the keystone of our campaign strategy. We know that some progressive representatives and senators in the legislature refuse to display leadership on health care reform because of this cynicism. We must disabuse them of this false conceit by demonstrating that the people in every corner of this state believe in, deserve, and will fight for justice in all spheres of life. To do so, it is essential to rebut the notion that government is the cause of all our problems and privatization is the solution. We may be flexible in adapting our language, messaging, and attitudes to varying conditions across the regions and demographics of the state, but we will not compromise on the principles of programs that incorporate our shared values. The fulfillment of these aims requires that we build a movement which will overcome the powerful, wealthy forces oppressing us, as was done in the civil rights, women's, and gay revolutions, and will be done for immigrant rights. To have predicted the achievements of these movements that seemed impossible a short time ago would have been called unrealistic. I remember Southern politicians admonishing the civil rights leaders to go slow. Now, even some Democrats in Congress offer to compromise with the Republicans to delay the implementation of Obamacare for a year, in which 47,000 people without access to health care will die of treatable causes. Still, we are denied the fulfillment of our dream for justice. The dream is real, but we have to wake up to realize it. That means creating a loud, visible presence of activist organizers in a network covering every county, district, town, and rural outpost of the state, not just the liberal metropolitan enclaves. With the reach and strength of our members, we can inoculate our constituencies against the distortions and lies that the wealthy stakeholders will use to manipulate, threaten, and buy off the public. The time for us to act is now. The opposition has mounted a wall of massive resistance against the Affordable Care Act, just as the Southern Democrats did against school integration over 50 years ago. They are forcing the administration to respond with an expensive advertising campaign to promote the exchange. Insurance companies will spend $1 billion to encourage people to sign up, adding to their already too high administrative costs. We must be ready to spread the word about real reform to every citizen in every part of the state. We can cover Oregon with the truth. This is a challenging task, and I have no doubt that we are equal to it. When I think about the morality of our campaign, I don't think about the achievement of the rights we deserve. I think about the moral force that confronts us as individuals and community, which makes it incumbent upon us to do our utmost to fulfill the promise. Citizenship is not about prerogatives, but obligation and duty. The timeline of how our strategic goals will be implemented follows. The results of the finance study must be presented to the legislature by November 1st, 2014. Beginning now, the legislative strategy calls for interviews with legislators to engage them on the plan for health care for all Oregon and to assess their level of support. In the 2014 campaign season, Hcao will interview the candidates. Among the questions put to the legislators will be whether they agree to advance the recommendations of the finance study. Representative Dembrow has alluded to his plans for a reintroduction of the bill to create health care for all Oregon. Depending upon our efforts on its behalf through lobbying, rallies, letter writing, and a media campaign, it will pass in 2015. Then, upon determining whether to support the ballot initiative or to support a referral from the legislature for a vote by the public on the measure, we will have a year to mount a petition or get out the vote campaign, rivaling the scope of elections to statewide office in 2016. Assuming it passes, we will request waivers from the federal government in 2017. To accomplish all this, we must build a massive grassroots movement of volunteer activists to carry the message to the legislature and to the people across the state with a force which will withstand and overcome the power of the vested interests of the medical profiteers. This will require a lot of money. It's incumbent upon us to organize this money as well it is to organize the people who are working in the campaign. Dedication to this is something that's just as important as it is to mobilizing people. Our database of such individuals has grown over to 7,000 across the statewide movement. We're growing through house parties, tabling at community events and forums. We ask all of you to step forward. Volunteer in whatever capacity you are willing and able to do. Respond to the call when you are asked for service. Commit to your member organizations and regional chapters to work in unison with our statewide organization to achieve the common goal. The opposition is well-financed and sophisticated. We have the wealth and wisdom of the people and the power of righteousness.